Hello and welcome. My name is Ilana Robertson. I'm the Vice President of the Washington Global Health Alliance, as well as the Executive Director for the Global Health Innovation XCHANGE. Thank you for joining us. We are excited to see you today, and we are here today to discuss on global health innovation. If you would like in the chat, please share with your name and organization so we can see who's present today. Our special first webinar today will be centered around the topic of global health innovation across sectors, and we are honored to have Ricardo Silva, the Vice President of the Foundation of Living, Wellness and Health with us today. He will be presenting on the topic of global health innovation and he will also moderate the discussion with today's panelists. Currently Professor of Health, IT and Health Innovation at Villanova University, Pennsylvania, Ricardo is a senior consultant to the WHO. He's a serial entrepreneur and aspiring science fiction author. Broad international experience, mostly in Latin America, and particularly in Venezuela and Ecuador, where he helped develop the innovation accelerated ecosystem along with academic industrial partnerships. Ricardo, I will also go ahead and now pass it off to you to start today's conversation.
Thank you, Alana, and it is a pleasure to be here with all of you. So good morning, afternoon, and evening, wherever you are in the world. And let's get started with today's forum. So next, when we think about innovation, the first thought is that you have a very bright person, and somehow this very bright person goes to a place where, let's click it there. Kyla? There we go. So someone comes with a very fancy machine as thing structure and finds that idea in the middle of the mind, and somehow that idea can then be connected with, let's go, Kyla, to the next. Yes, there we go. So we connected with a think maker. And surprise, surprise, let's click that again. A product is printed. And this product is already tested, can go to the market, and my idea becomes $1 million. Well, this is not quite the way it works. So let's go to the next, Kyla. The process is a little more like this. Let's click it there. You have your person with the bright idea. This guy has to go through a lot of ideation, papers that are going to be tossed away because they didn't work, until finally they are able to put together a proof of concept prototype, something that actually works. That breadboard with cables, it's capable of doing something. From there, they can move to a testable, workable prototype that they can show other people. And some publications, some papers may come out of this, because this is typically what happens in academia. This first part of the cycle is what we call research. Let's click the next one. From there, we move to the bottom half. So hopefully, the people who worked on the research side came up with intellectual property that they could protect through a patent. This patent becomes an actual workable product. Now, this product, because we are in healthcare, needs to go through countless sessions, clinical trials, accreditation, validation, you name it, until finally you have a product that can go to market. At this time, we have ended the development phase, and it is just here when we truly enter innovation. Throughout all of this cycle, we were taking money and turning it into knowledge. Finally, when we reach commercialization, we can take that knowledge and turn it into money. That's what innovation is all about. Let's go to the next guide. Okay, but innovation is not just about products. Yes, we can make cheaper, smarter, faster, smaller products. But innovation is a lot of other things. What about services? What about taking drones and using them to distribute medicines to rural areas and low resource settings? Or setting up all of the devices that we need for telemedical interventions so that we can do remote telemedicine? Or incorporating traditional healers and traditional medical practices into the greater healthcare system and allowing them to exchange information with one another, or providing people with perhaps small training with tools that will allow them to, for example, monitor a pregnancy and exchange that data with those with more knowledge that can provide the proper advice at the point of care, home care, or simply the use of apps that will allow us to know where services are located, how to access them, or even how to call for an ambulance if we are in need of it. So products, process, systems, integration, it's all in the world of innovation. Let's go to the next guide. Sometimes innovation can be much simpler than it appears. Neonatal babies, incubators, controlling their core body temperature is fundamental. But that is true if the outside temperature is cold. But if the outside temperature is hot, let's say 42 degrees Celsius, we actually do not need to warm the babies. We actually need to cool them. And many times, let's click the next one. What WHO has showed us is that what we need is maternal care. The Kangaroo Baby Project has saved many neonates, and it is an innovation that doesn't cost a cent. So innovation is not just about money. It's about thinking different and making an impact in the real world. Let's go to the next guideline. Truth be told, no one can do everything by themselves. This is a team effort. This is a team game. We need to connect the inventors, the universities, with the suppliers, with the manufacturers, with the government entities, with the regulators, with everyone, so that we can actually build the infrastructure that will allow an idea to become a solution. That idea to receive the money so that it can become a product or a service or a change that can then be incorporated into the world of healthcare and make a difference. Let's click it there. That is what the exchange is all about. So what we are here for is to learn and meet some of the connectors, some of the nodes in this great endeavor. Let's click the next, Kyla. So with this, let me introduce our great panelists. And the first person, ladies first, is Rebecca Milner. She's the Chief Advancement Officer of the International Medical Corps. Rebecca mobilizes partnerships, resources, and awareness in support of international medical corps that reach 20 million people a year globally. They provide life-saving healthcare and training that builds self-reliance for people in the front lines of war. That includes Ukraine, Gaza, and Sudan. Besides Rebecca, we have Sudesh. Sudesh Sivarasu is the South African Research Chair in Biomedical Engineering and Innovation at the University of Cape Town. And he's also the Director of Biomedical Engineering Research at UCTB Biomedical Engineering Research. He is a prolific inventor with more than 65 patent applications, over 22 different patent families. 26 of those have been granted in different parts of the world. He also has 3 open source innovations and 3 startups. One is Rescribe Therapy, Impulse Biomedical, and the VAS MedTech. Of course, he's also a recipient of multiple awards. And last but not least, we have Dr. Jitendra Sharma. However, Dr. Sharma was called upon a very important meeting, and he's not going to be physically present with us today. I'll introduce him, but he shared a great video that we're going to be looking at shortly. He is the managing director and founding CEO of the Andhra Pradesh MedTech Zone, the A2C, or A2Z, like they like to call it, in health, technology, and innovation. That's the largest world device research and manufacturing park located in Vizag, India. He's also founder and executive director of the Kalam Institute for Health Technology, which serves as a policy institute and advisor for various institutes at the India government, including the Ministry of Health. And of course, he has received multiple awards, and he is the author of, I don't get to see this properly, there we go, of this very interesting book, Made in Lockdown, that tells the story of how AMTZ began from an idea, and it's now thriving ecosystem for healthcare. Well, so without further ado, let's see what Dr. Sharma had for us.
Medical technology has a pivotal role to play in the healthcare autonomy and access to healthcare. Access to healthcare is the principle on which even autonomy rests, because unless there is access, the choice and autonomy would not set in. Now, access to medical technology is a dialogue which is being discussed across the world. Health technology, whether it is oxygen concentrator that was needed in COVID, or a simple pregnancy test kit in many parts of the world, or a CT scanner for accident diagnostics, or an MRI for tumor identification in cancer care, are all part of a very cohesive and comprehensive health system which needs to be harnessed, synergized, and invested upon. I represent AMTZ as its founder, CEO, and managing director. AMTZ is today world's largest medical technology research, development, and production cluster with over 142 companies, over 300 partners, including investors, bankers, logistics experts, and over 6,000 people, converting the dream of access to medical technology in India and globally a reality. What do we do, and why do we do? Medical technology requires very high investment scientific facilities. These facilities are required for validation, testing, certification, without which production is not possible, as regulatory approvals would then stop technology from entering the market. And therefore, investment by government on scientific facilities is much needed for promotion of medical technology and higher access. This investment can happen in broadly 2 categories. Category 1 is the investment required on infrastructure for testing, validation, trials, and so on. And category 2, investment that is required for prototyping, designing, batch production, 3D printing, which would go into as components and raw materials for the final product. This is necessary because this allows investment value chain to set in, taking advantage of the ecosystem. The government then allows investment to come in to produce a much higher bandwidth of medical technology and gains in 3 ways. 1, the creation of jobs which are required for medical technology production. 2, the goods and service taxes that come out of the production value chain, allowing government to reap benefits out of its investments. And 3, the ability of large-scale production to minimize the cost of medical technology and health product, allowing government to procure them at a much lesser cost, thereby saving economic value. And therefore, right from job creation to tax revenue to affordable procurement, allowing governments to serve more number of people or number of people in much better ways with more access to medical technology all becomes a reality. This then allows a resilience to set in the ecosystem in a province, state or country. This resilience of course allows one to strengthen the supply pipeline in emergencies, disasters, things like COVID, eras where there are conflicts. We have the experience of supplying prosthetic limbs in conflict zones as well as 1 million RT-PCR test kits a day during COVID, almost 1,000 oxygen concentrators a day. All this allows sustainability of healthcare operations in a country despite the changing environment. Additionally, the nodes which we call as medtech ecosystems then starts to compete with the rest of the world and compete positively, allowing the value systems and efficiencies to actually impact other clusters across the world. Also, the other clusters and other producers around the world then look at fair pricing because there is one ecosystem or cluster which has actually achieved it, setting in a competitive pace for improving access and improving affordability for healthcare technologies. That generates global goodwill and public good. I'll stop there, but feel free to write to us if there is any manner in which we could support, collaborate, allow cross-bridging of investments, ideas, and more importantly, co-creation and co-production of health technologies to improve access and affordability. Thank you and namaste from India.
Thank you and namaste to Dr. Sharma. So Dr. Sharma was not here with us today. However, he sent a great proxy, the best proxy that he could have, which is Krishna Kant, who would be happy to answer questions in a couple of minutes. But before we open the forum to public questions, there are a couple of questions that we would like to ask. And let me start with you, Rebecca. We talk a lot about low resource settings, but you go even further. You go to resource constrained settings. You go to places where war is taking place, where things are hard to do. So how do you implement solutions in these environments?
Thank you, Ricardo, and thank you, Alana, and the Washington Global Health Alliance for having International Medical Corps be part of this conversation. I mean, as you say, Ricardo, we're boots on the ground, and the population that we serve, there are more than 1 billion people who live in conflict-affected and fragile contexts. And they have high levels of extreme poverty with poor health outcomes that impact people's ability to work and contribute to the economy. And that's the context in which we work. And as a global humanitarian organization, we have to adhere to sort of the basic tenets or the fundamental principles of humanitarian assistance, which is do no harm. So we really have to carefully choose what innovations and technologies that we're going to champion. And as our business is emergencies and saving lives, we're also always interested in learning about new technologies that might make our jobs easier. However, in the middle of an emergency, like what's happening in Gaza or Ukraine, that's not the time, right? And so, when we think about innovation and implementing new technologies or whatever, there are sort of several things that we have to keep in mind. One, innovations need to target persistent problems. They can't just be tailored for a single emergency or context. So, often some of the tools that we are approached by with innovators, that approach us are developed in non-emergency settings, and really a lack of understanding about, what resource constrained environments are really like. And so, the technology has to be fit for purpose. And then secondly, everybody has to be aware of those resource constraints and how much time it takes to implement new technologies. Because, while it may be a priority for the innovator and for International Medical Corps, there are lots of people that are part of the global humanitarian architecture, and it may not be a priority for that community or that country or that Ministry of Health or whatever. So it has to be something that everybody is trying to solve. And then education, training, and socialization is an incredibly important part of it. You can't just sort of implement a technology, do one-stop training, and then expect it to sort of scale and take over, right? The education, socialization, really, all of that takes a lot of work. And the monitoring and evaluation and all of these things really, need to be in place. And we need to make sure that there's an evidence base for the effective innovation. And then I think there needs to be an understanding that even in these places where kind of chaos often reigns, there are people in charge, right? And those governments, those ministries, those local leaders, all of that, they really need to be involved. And it needs to be driven, right? These solutions really need to be driven to answer those persistent problems in those communities, but also something that's appropriate for those communities. And then finally, funding. These aren't, necessarily new markets, right? There's not necessarily going to be, a business case that can be made for some of these innovations. And so you have to bring funders along. And everybody knows how to deal, how the funders work. It's a slow process, and it's an engagement process. And so I would think that those are sort of the fundamental things that need to be in place before you can implement a new innovation in a humanitarian context.
Wow, wonderful, Rebecca. There's so much in what you said, and we will try to take things out as we go. But let me take two of the things that you mentioned. So one is funding. As an entrepreneur, I know that funding always comes when it's no longer needed. So once you're up and running, it's easy to invest. But early stage and getting money when you need to move through the pipeline, when you need to take that idea, that research into a prototyping stage, and from there into development, that's highly needed. And with that, I want to move to Sudesh, because that's precisely the world where he navigates. So Sudesh, how do you select those projects and take them through the pipeline?
Thank you, Ricardo, and thank you, Elena, and the Global Health Innovation Alliance for this opportunity and to be part of this fantastic webinar. So there's a lot of pointers that the previous speakers actually mentioned, and I would like to kind of touch on that to begin with. I think the point around funding is a massive roadblock, but also a massive opportunity. But before going into that, let's start with where the actual problem is. if you're trying to solve a problem, especially around the medtech space, one of the key things that we encounter is it's the technology push. It's in a traditional sense. I've got a hammer. I'm looking for a nail, and I'm kind of having a machine learning tool that I'm going to be putting on everything that I see. And this is rather not a right approach, as many of the members who are on this call may also understand that very well. I want to give a number, and I would like to see if anyone is able to pick that number as of today. 5392249962. That's a number I want all of us to look into. That is derived from another number, which is 8088223743. Okay, to make it easy, 8088223743 is today's population, and of which 5392249962, about 5.4 billion people do not have access to appropriate technologies. And that's, if we have made all the innovations that we have done so far appropriately, those 5.4 billion people will have access to technologies, the likes of technologies that Rebecca was just mentioning in war-torn areas, the like of technologies that Dr. Sharma was mentioning when there was a need to develop 1 million RT-PCR in a day. That's still lacking. 5.4 billion is a massive number, and that's a massive market. But what is really happening for us? Why are we not able to untap this 5.4 billion people with appropriate technologies? It goes back to the fundamental question: who your client is. Are you responding to a technical problem? Are you responding to a clinical problem? And that's where I would start. I would start with actually trying to solve a problem that is clinically relevant, solve a problem that is socially relevant, solve a problem that will actually make a clinical and a social impact. It kind of goes back and building further and further into, first question, what is the problem you're solving? Who's the problem you're solving this for? And very important question, which actually answers the funding question: who's going to pay for your technology? Right? So if we do not understand the ICD-10 codes relating to the payment limits of each of the innovation that we're going to be building, we could end up creating the Rolls-Royce of the world. If the ICD-10 code only allows $100 to be paid for that procedure, how do you actually make it match? So that's one way, we actually could look into problems and try to emphasize on how do we solve problems relating to technologies in an appropriate manner. And another critical factor, and I think this many of the fellow attendees of the webinar might also understand, this is the innovators come up with very brilliant ideas, but the IP landscape plays a much crucial role, because the innovation conversion is not going to be easy without an appropriate IP backing. And IP, the stronger the IP, the stronger the investment potential. And Ricardo, you mentioned about the amount of money it takes to go into the market space. And let's give it a simple thought. We have more than 10,000 types of medical devices. Just more numbers. Today is the day for numbers, so we'll speak more numbers. We have more than 10,000 different types of medical devices to begin with, of which 35% of the medical devices are class 1 devices. 53% of medical devices of the 10,000 are class 2 devices, and 9% are class 3 devices. Okay, 35, 53, and 9. And if you were to convert that 35 and the costing relating to this, each class 1 medical device ranges from anywhere from $50,000 to $1.5 million to take it to the market. Whereas a class 2 medical device takes about, on an average, $37 million to take it into the market. Whereas a class 3 medical device takes about $112 million to take it into the market, right? Where is that backing going to come from if you don't have an investable IP, right? It's the world is great. We could look into a lot of open source innovations, and this is a conversation me and Ricardo had in the preparatory session. That's a webinar on its own. But where is that kind of investment going to come if we don't plan for that, and if we don't plan for who's going to pay for this, and if we don't plan for where whom are we targeting, and whether whose pain points are we trying to solve, and in what kind of purchasing capacity would our players be able to come into the space. And Ricardo, you must highlight when I should actually stop on this, because this is a passion project for me, and I can keep talking for hours around this.
Well,
thank you, Ricardo.
Great, Sudesh. No, I mean, again, this is such a rich conversation. So let me take what you just said, and since you started putting numbers, I'm going to add some more numbers to the list. So you talked about the money it costs to develop an innovation. You didn't quite mention the time. So the average time is about 15 years, and the time for a patent is 20. So that means that during 15 years, you're just shoving money into the beast, and then hopefully within 5 years, you want to try to recover that money. And that's one of the reasons why people don't understand why medical innovations are so expensive, because it costs a lot of money. Just an average, very simple clinical trial can cost $2.5 million. And that's a small trial. So the more complex the product, the more money it's required to make it happen. There are two other numbers that I want to bring to this picture before going back to Rebecca. There's a lot of people in the world. Indeed, there's 5.4 billion people in need for healthcare. But according to the latest resource I found from 2019, there are only 12.8 million physicians, 29.8 million nurses and midwives, 4.6 million dentists, and 5.2 pharmaceutical personnel. We do not have enough people, no matter how we look at it, to serve the needs of the population. We need technology to help us bridge the gap. Without innovation, we are not going to solve the problem. And getting back to Rebecca and big numbers, today or last year, according to the United Nations, the world has 117.2 million people displaced. Those are the individuals that you serve. Can you give us an example of how have you successfully implemented an innovation in these constrained settings?
Yeah, absolutely. So all of the comments that Sudesh and everyone has been making totally resonate with us. And the innovation that I'm going to talk about today is a software innovation to help us do a better job managing our pharmaceutical pipeline. So as a health service delivery organization, right, one of the kind of persistent problems that we had was the inability to kind of have visibility into where, how, and when the medicines were being used that we procure for our programs. So there are a lot of softwares out there that help you get from procurement to a central warehouse. But once there's a central warehouse in, let's say, Nairobi, what happens after that? And how do you reach the last mile, right, with these solutions? And just, again, to add some numbers to this, in low resource settings, an estimated 60 to 70% of funds spent on procurements are wasted due to lack of visibility, right? There's medicines expire. They are not properly managed in a warehouse. The cold chain isn't kept, or whatever those questions might be. And that's a lot. I mean, International Medical Corps by itself, a single organization, spends about $35 million to $40 million a year on pharmaceuticals. And we needed to be able to really do a good job in managing that. So our team, really a doctor with some programming experience that was working in Jordan, he and the team developed this sort of software to help us manage our pharmaceutical pipeline. It's a barcode on medicines and commodities that tracks our inventory and traces it all the way from the warehouse to the individual patient. And we have 99% accuracy on that. The system, of course, operates offline, right? It's an Android-based system. It's a software that's designed to capture kind of key data at every level that allows people to make data-driven decisions. I mean, I think all of us have been in a context in, let's say, Ethiopia or South Sudan, where you've gone to a health facility, you've seen the big books with the multiple pages that, may have water on them, or, things that might have gotten smeared or whatever, but everything is still manually done. But we introduced this software in these pharmacies that are kind of at the end of the last mile. And it's been incredibly successful since 2019, although the development of the software started in 2015, which, to your point about, it's nearly 10 years later. So since 2019, though, we've deployed the PIMS application in 193 health facilities in 18 countries. The software is available in English, French, Arabic, and Somali, and we're also working on Amharic for Ethiopia, et cetera. So as we're sort of beginning to scale, we're adding all of these things. So the impact of this has that it's reduced our International Medical Corps stockout rates for medicines to less than 3%. I mean, and that's critical for the women and children that are coming to them. 10% less prescribing of antibiotics. Really important when we're all dealing with antimicrobial resistance, right? 0 adverse drug interactions. So the system will flag when there are potential conflicts between the drugs that your patient is taking. And it's reduced waiting times for our patients by 88%. So there's some serious outcomes there, and it allows the team at headquarters, wherever they might be, or at the national level, to have visibility into what these pharmacies are using, how they're dispensing medicine, and what's happening to the medicines as they do that. So this is really, I think, an innovation that was driven from the end users, right? They sort of piloted it, or did the initial one. We put in additional resources, programmers, time for that, and then we began to test it within our own facilities. And now we're in discussions with government facilities throughout Somalia, Central African Republic, South Sudan, really about integrating them into Ministry of Health pharmacies and health facilities. And that's where we're really going to make an impact. And so we're very excited about this. And Kayla has a PDF and a link to the Pharmaceutical Information Management System, PIMS, in case there's any interest in more of that. But I think that this is really, it reflects, I mean, all of the things that we said kind of need to be in place, right, for an innovation to be successful.
Wonderful, Rebecca. So yes, not only Kyla has the information, but in the chat, we actually have a link to the PIMS system. So for anyone that is interested, you share the link, it's available. It's wonderful. You mentioned, again, many of the issues that we've been describing throughout the conversation. One thing that comes to mind, Rebecca, and again, to move towards Sudesh, is involvement. So how do you get people involved in all of the different aspects of the projects? And another one that we have not discussed, but actually becomes super important if we want to make a difference, is the success rate. You mentioned how much money is wasted in the procurement process, 70%. And there's a lot of wasted money and wasted resources throughout healthcare globally. So coming back to Sudesh, in your experience, what is the success rate for this sort of innovative projects?
Fantastic, Ricardo. We always talk about the ones that have become successful, and we actually do not reflect on what did not go successful or what was not a success. And it's quite good for the innovation community to actually look into that very closely. There is a lot of lessons that one could learn from it. Okay, so I'm going to pick a review that actually talks about innovation on a larger scale. What is the avenue of those innovations becoming successful? So one of the major business reviews, I don't want to cite which one it is, you can look upon it, indicates that close to 90 to 95%, it ranges from the geography where this is, 90 to 90%, 90 to 95% of every innovation that is conducted globally fails. 90 to 95, which actually means that for every $100 that you're spending, $95 goes into the drain. What's also interesting in that review is that the success rate of innovations coming out of academia or academic research institutions, if you were to take a guess, you would want to assume that it's going to be better than that 90 to 95% that is happening elsewhere. The shocking stat is that 97% of all academic innovations fail. It's 2% more failure compared to general innovations that happens elsewhere. Why is this happening? Let's look into it. This is a classical question, and I want to pose to every health innovator out there in the space to say, will a paper in Nature save a person's life? Maybe, maybe not. But what's quite important is that 97% of innovation that fails, academics are more keen in getting a paper in Nature or Lancet. But let's focus more on why, the 3% that actually succeeds. We need to understand that the chasm or the chasm of innovation translation, or the valley of death that we traditionally call in innovation, there is this transition from academic environment into the industry environment that usually happens, if you were to use a reference point of scale, the technology readiness level usually happens about TRL3, where the scale of technology readiness level starts from 0, which is your idea in your head, to TRL9, which is a product that is ready and running, which is a NASA scale that is we could use that as a reference. So traditionally, academic universities are good in doing research from TRL0 to TRL3, but industry is pretty much good in doing the rest. But what happens is this translation from academic environment, the TRL3 to TRL4, TRL5, that is not properly documented globally. And it's very important to understand that it's critical to have this pipeline of innovations, but to have this transition well documented for medtech innovations, because unlike many other industries, medtech innovations, the industry is very highly regulated. It's critical that at a very early stage in TRL2, TRL3, TRL4, we start to talk about the importance of managing quality management systems, including ISO 13485s in the conversation, including ISO 9001s in the conversation, 14971s in the conversation, or 14155 in the conversation, because it's quite critical. If you don't have any of these in place, your innovation is deemed to be a failure. So coming back, so this is the framework that we are working in. The innovation needs much more stringent design controls throughout the process. And it's quite important as an innovator for me to understand and map out the life cycle, the entire life cycle of the innovation. And if I don't have it mapped out, it's it's going to be extremely difficult to figure out what is it going to take, the cost of innovation ownership. What is it going to take from your ideation to giving it to the hands of people? So it's quite a long cycle that one is going to attempt without actually having much of success. So by incorporating innovation support, innovation management support, we are able to reduce this innovation failure rates from what was previously about 97% failure rates to about 80% failure rates. But this is a very rare one-off scenario. And places like AMTZ is another classical example of how they have incorporated an ecosystem around which the entire innovation revolves around, and the chances of failure is reduced because you don't have to wait, or you don't have to send your device all the way from South Africa to Europe to get it tested for your TUEs or for your certifications for CE. AMTZ has that sorted out within their campus. It's also about bringing in the physical proximity of having these facilities, because by the means of it, it also creates the awareness that each of these technologies will have to go through this process. So there is a need for actually having a larger discussion, a larger community of practice discussion in the health innovators space. And this is not only about solving the problem around your unmet clinical need, it's also about solving the ecosystem problem that kind of builds around the entire range from product innovation, clinical evaluation to post-market surveillance. That whole pathway needs to be mapped out. And there is a need for sensitizing our innovators in that space. And I think that's something that a platform like this would be ideal space to get those conversations, those communities of practice get going. Thanks, Ricardo.
Sudesh, wonderful, 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 wonderful. And yes, I'm going to get to you, Rebecca, in 5 seconds. But you mentioned so many things that resonate with me. But one thing that I would like to emphasize, and part of, in my opinion, the failure rate, is that we think that the person with the idea is the same person that is going to run the business. And that is a mistake. Yes, there are few exceptions. There are the Elon Musks that can do everything, but that's not the way the majority of the people think and work and resonate. I mean, an inventor loves to be inventing, not necessarily selling products, and so on. So we also need to understand that this ecosystem needs to feed the right people into the right places at the right time, because that's the only way we're going to succeed in this very complex changing environment. And with that, I'll come back to you, Rebecca. And since time is of essence, I'm going to make a little connection with a big picture question that Fred Hosea is asking. It's a typical question, but it's directed to you. You are working on crisis. You mentioned how this software has been translated to multiple languages so that it can serve the needs of the people at that last mile. So even though there are subtleties that are required for each country, each last mile, each scenario, there's still a bulk that needs to be maintained so that the system as a whole can flourish. Fred is asking about polycrisis. So in your experience, and you've dealt with polycrisis, how does this bulk versus last mile interaction need to be solved in order to be successful?
That's a really good question. Although I do want to say something around the appetite to discuss failure and to allow things to fail, because in the private sector, I think that there is an understanding of what that means, and that there's still a 1 in 100 chance of hitting it big and paying off. But in the public sector, failure is not, I don't know if I want to say tolerated, but it's very difficult, right? It's very difficult to go to your donor and say, oh, you invested all this money, but it didn't work, and we tried. So I think that there's a difficulty there, and that's a challenge, and I don't have a solution for that. But I would just say that as you're talking about these really low resource environments, it includes public donors, and that is its own challenge, right? Because they may, one administration or one donor may be in favor of it, another donor might not. It's you're kind of at the mercy. And I think it is all complicated by this sort of multiple layers of crisis on top of crisis, right? We're in a state, really, a global perma-crisis, right? I mean, and so it's used to be, we respond to emergency, and then we come back, and then, but it's not really that way anymore. And so I think one of the reasons that PIM is so successful is that it does solve that problem that is persistent across all the humanitarian, kind of realm there. And it can be something that is implemented, but International Medical Corps is still supporting it. It's not open. We do have IP protection for this software. We would still be supporting it as different ministries or other organizations implement. So it could be potentially, eventually, a revenue generator for International Medical Corps. But, you know, we are not, you know, a software company, right? So and that comes with its own set of kind of challenges and everything there. And so as an organization that has this innovation that we think can really add value to the entire community, to countries, you know, whole kind of health systems, you know, we're going to have to incrementally make progress on this. We have, with Somalia and Kenya and Central African Republic in particular, you know, we think that if these ministries adopt it, it would be something that would be much more accessible. We have brought donors along. The European Union, the ECHO, the humanitarian arm of the European Union, has said that this is a kind of solution that organizations should adopt. So it's a slow, incremental progress. And then I just also wanted to share one more number that I think would be really interesting to people. As we've trained our pharmacists and our frontline health professionals on PIMS, 40% of the pharmacists that we're training have never touched a computer before this point. So that also shows you what we're dealing with. I mean, there is just huge inequities, right? And so we, in, you know, more developed countries, think that we have this, you know, great solution, but it's going to require a lot more support to implement something like that.
Rebecca, that's so great what you just mentioned, but I'm going to shift it a little bit, because that's true. The inequity computer systems, but most everybody in the world has used and have access to a cell phone, and your solution is built for Android, right, which has the largest penetration. So that it's also super important to understand what are the true needs and technologies that are accessible to the people. And believe it or not, there's better cell phone coverage in rural Africa than in rural US.
Yeah.
And
amazing. Yeah.
And we need to understand these things if we actually want to make a difference, if we actually want to produce an impact. And let's go back to what Sudesh mentioned, which you emphasized, and even a question was asked, and it is failure. Not just government organizations. We have this thought that people do not learn from somebody else's mistakes. But that's not necessarily true. We do not learn because we didn't even know that they made the mistake before, because no one shared those mistakes. Right. And you mentioned something interesting, Sudesh, and let's start moving away from the structure into a more unstructured conversation here. And that could have to do with the exchange. What do you think about working on providing a database, a repository, or however you want to call it, even a journal of failed research? What are your thoughts to that respect?
Ricardo, I'm not sure if that question is targeted towards me, but it looks like you have actually listened to something that I proposed to my university's research symposium like 4 years ago. And we were talking about exactly the same point. You know, there are lots of failures, and these failure stories do not come out unless you are in a mentor-mentee relationship. You know, unless you're in a mentor-mentee relationship, you don't actually share what really happened with the innovations that failed, with the technologies that failed. I think there is an opportunity for us to actually create a journal of medtech failures and try to document what was the learnings. You know, rather, you know, it's kind of a very unpleasant journal of failure, but you know, you could actually, you know, phrase it as Journal of Learnings or something of that sort, so where we can actually document all of this. I think it's also quite important to understand why we are not able to document these failures. And as Rebecca rightly pointed out, there is these funders' obligations, which is always a hanging knife above our head, because if I don't meet this milestone, my next tranche is going to be cut off, and my staff are going to be affected, or I'm going to be directly affected. This kind of creates this anxiety about innovators to actually positively reinforce everything that they are seeing and try to create a confirmation bias on every innovation that they are working on. And I think that's something that we should sensitize our innovator and innovation community to say it's okay to fail, and it's to say this is normal, because it's not just you, it's 97 out of 100 people, 95 out of 100 people, or 95 out of 100 systems that are going to fail. And you at least are learning how not to do it the next time around. Or, I think it's also, you have to take a couple of steps back and try to see why this is actually happening at this massive scale. If you're going to take a flight, and if 90% of that flight is going to fail, will you take the flight? You will not use the flight to commute, right? Why are we allowing this to happen repeatedly? I think it goes back to the fundamentals of definition. It goes back to the fundamentals of us not having the idea about the full landscape, full life cycle. It goes back to the definition of who's our target, whom are we targeting this, what is the targeted use case? It goes back to that definition. It goes back to the definition of a minimum viable product. It goes back to the inability to define between the needs and the wants. And I think that's something that we as innovators would need to start nurturing and start creating this sense that we define something very clearly, and then we can start working with it, right? And I will stop there, and I will get Rebecca to top it up.
No, I mean, I agree. I mean, and it is a discussion among all of us in the humanitarian community, really. How can we begin to have a frank conversation, and how can we overcome some of those challenges, really? Because a lot of the failure is kept within an organization and isn't shared across the sector, which is a shame. But mostly it's because we're dependent on donor funding, and, people back success, right? They want to back, the organization that's, got a stellar reputation and stellar program implementation. So I'm not sure I have an answer, but it's certainly a challenge that we have to kind of figure out how to break down and talk about.
Rebecca, Sudesh, I'm going to add a cherry on top of that. Not only funders want to pay for success, there's also a big punishment for failure. In the United States of America, in particular, if we make a medical mistake, the consequences are enormous, especially monetary. So people do not want to share failure because that may be a cause for punishment. Tom was sharing in the chat a couple of seconds ago that aviation got better as people were stimulated precisely to disclose those failures. So we should learn from aviation. They have been doing it well for a very long time, and see what good practices can we borrow from them and bring to healthcare. But with that, I'm going to go back to Alana to close our session.
Thank you very much, Ricardo, Sudesh, and Rebecca. And thank you, everybody, also for submitting your questions and for the discussion. It was really an amazing conversation, and I hope the beginning of many more. We've got a lot of questions around AI and digital health. So our next session will be on digital health. And you can register for that today already. And we will be featuring Les Becker, from the Chief of Innovation at the Washington State Department of Health. He will be moderating the discussion, and more details to follow. So this concludes the formal programming for today's event. Thank you all for joining us. For all of you who are interested, feel free to stay on this Zoom meeting. Some of the speakers will be staying on to answer additional questions and or participate in further discussions on the topic discussions below. Thank you again, and have a wonderful day further and the rest of the week.